Very well welcome, everyone, and thanks for making time to connect and listening to the webinar session today. So as per the invitation that you received, our webinar session today is going to focus on sharing experiences on adaptation of the on doing equity analysis, especially using the VERSE toolkit and adaptation, especially on adaptation of the model to local contexts. As we realize that in many of the programs that we do implement, several of them do not put it into consideration. So this is the part of the purpose for this webinar session. And so I'll start off by introducing myself. So Anthony Ssebagereka is my name, and I am a research fellow at the School of Public Health at Makerere. And we'll also quickly introduce our speakers today. So starting with starting with our chair for the Department of Health Policy Planning and Management, Dr. Suzanne, who will start us off with the introductory remarks. Then later we'll have Dr. Bryan Patenaude, who is a professor at Johns Hopkins University, and he will be speaking about the VERSE toolkit and the methodology that has been efficiently developed and used to measure equity assessments and metrics, even that also being able to adapt to local context. Then we'll also hear from Dr. Ronald Kananura, who is also a research fellow here at the School of Public Health, Makerere, and he will be sharing his experiences in conducting distributional cost benefit analysis against something really based on this methodology, but expanded to other areas. Then finally, we'll also hear from Dr. Jaffa Okering, who is a senior data manager at IDRC, that is Infectious Disease Research Collaboration, and he will also be sharing with us hands-on experience in terms of what he's going through, and probably to interest other colleagues who might want to do similar things. So we'll be sharing probably what it takes and in adapting the VERSE toolkit and also conducting equity assessments within our local context. So without further ado, I will invite Dr. Suzanne Kiwanuka, who is our chair, Department of Health Policy Planning and Management, to give her opening remarks. Over to you, Dr. Suzanne.
Thank you very much, Dr. Anthony. Good afternoon, everyone, and you're most welcome to this, our first series of planned webinars. As a department, we plan to hold these more regularly with a goal towards sharing the work we are doing with a wider audience and hopefully learning from each other, but also benchmarking the different pieces of research that are taking place, not just within the school, the department, but beyond. These webinars are being scheduled. There is a plan to schedule these perhaps monthly, and we upload this team for taking up the first slot, and hopefully we can improve its coverage and of course the benefits thereof. With regards to health equity, this is work which has been done within the School of Public Health with a team from Johns Hopkins, and we appreciate what was done, and we desire to learn more. Personally, I have done a bit of work on equity with a team working on the family planning study, and one of the things we actually learned was that we frequently measure equity with regard to socioeconomic status, access to health, but there are other indicators which could perhaps be even more vital within other contexts that we leave out. For instance, for family planning, we found that even equity in access to messages is very important, because uptake of family planning is driven by behavior, which is driven by awareness. So we found that despite many messages on family planning that have gone out, because of the inequity in access to the messaging across the populations, some of the people you would want to uptake family planning do not receive these messages. But access to messages, whether you call it, and I wouldn't call it health literacy, but rather being able to access the messages, whether they are online or over the radio, you will find populations which are not able to receive those. And that was a barrier to their uptake of family planning. So during that study, we realized that perhaps there needs to be additional measures of equity which can guide programming. And we are looking forward to hearing from this team. So without much ado, I'll hand this over to Anthony to steer the webinar forward. Thank you.
Right, so thank you so very much, Dr. Suzanne, for those opening remarks and a bit of insights. So we'll now welcome Dr. Bryan Patenaude, who is by the way, is not only a health economist, but also a professor of economic evaluation at the Johns Hopkins School of Public Health, a center for IVAC, and he's the PI for the VERSE global project, and he will be speaking to us more about what is this methodology about, how it was conceived, and probably what can be of interest within the space of academia and research. So warm welcome, Dr. Bryan.
Thanks so much for the introduction, and happy to be here. Gatien will do the slides. So as Anthony said, I'm Bryan Patenaude. I'm the PI of the VERSE project, the global project, which operates in several sites. One of them is within Uganda as well, at Makerere. And you'll be hearing from a lot of that team today. I'll talk a little bit about the background of the toolkit, sort of how we think about equity within the toolkit, what it does, some applications for it. So we'll be primarily talking about utilizing it to track progress in healthcare services and coverage, as well as equity in Uganda. But I'll highlight some of the other potential applications as well. Next slide. So just a quick overview of what we'll cover today. So I'll do an introduction of the VERSE approach to equity. We'll talk about some of the project collaborations. And then you'll hear about a multifaceted equity assessment done within Uganda, as well as stakeholder engagement. There'll be some demonstration regarding the VERSE toolkit, and we'll give a highlight of what's coming up in future research. So as an example of healthcare service throughout this presentation, we'll present routine immunization in Uganda, and we'll utilize the demographic and health survey data for the example that we'll highlight in my brief introduction. You'll also hear from some other data while we go through the presentations. And so with the appropriate data, the coverage and equity of a healthcare service can be assessed. And so this is going to be one of the crucial pieces. You have to have decent data to do equity analyses. Ideally individual data, but low level data, at least at the community or neighborhood level. And we'll see why that is as we go through the methods. Next slide. So we'll start with the healthcare service. And as I said, we'll focus on routine immunization and using the Uganda 2016 and here 2012 to 2016 demographic and health survey. You can see examples of different types of pediatric immunizations right here. We have polio, and the 1 and 3 refer to which dose in the sequence. So polio 1 is first dose of polio, polio 3 is third dose. We also have DTPT, so pertussis, diphtheria, and measles, MCV1, and BCG for tuberculosis. So you can see here the differences over time. You see a general growth in coverage of immunization services, but the real question with this is, was this coverage equitable? Who exactly were we reaching when we advanced coverage from, for example, BCG around 80% to over 95% or around 95%? Were those the most vulnerable of the remaining people that were reached, or were those people reached the low-hanging fruits, the easiest ones to get to? And these are important questions for how equitably rolled out a program is, and what exactly the program is designed to target. Are they targeting the most vulnerable, or are they targeting the easiest to get? And this is important to understand who's left out, how we get to them, and what types of programs might need to be implemented to reach those individuals. So in order to do this, we need to measure equity. And as was said in the introduction, equity isn't always one-dimensional. And it's also quite different from just measuring equality. So we need data, as I said before, we need pretty good data on individuals, their outcomes, what they're getting, the services they're receiving, and also demographic characteristics to really be able to do a full assessment. So the first step in this process is getting that data and then making an assessment from data. So whatever we're measure, in this case, pediatric vaccines, is that, can you expand this? You can just put the whole thing up. So are they receiving the healthcare service, yes or no? If the answer is yes, good. Okay, they're in the data. We don't need to do anything. We know that they've received the service, and that we can check if they should have received the service, but we know they received the service. If they don't, and you just take a look at the distribution of people who do versus don't receive something, that's inequality. That's different from equity. Inequality is telling us there are differences, there are disparities in the outcome, and they fall along some dimension that ideally we perhaps wouldn't want disparities on, like socioeconomic status or gender. But we don't actually know whether that no is no because they couldn't access the service, or no because they didn't need the service. They weren't eligible for some reason. So for pediatric vaccines, for example, we'll talk about age as a fair factor. So this is a reason why someone might not have received a vaccine, but still appear in the data set. So for example, if in the routine immunization schedule, you're not to receive measles first dose until you're 12 months old or 8 months old, then, and we see you in the data set and you're 6 months old and you haven't received MCV1, that's fair because you're not old enough by the schedule to receive it. So even though you're a child under 5 and you're between a certain age group, we couldn't have expected you to receive that vaccine at the time, but we want to make sure you've received all of the other vaccines that you should have gotten before 6 months by that time period. So keeping those observations in the data set helps us understand timely immunization, because some studies just eliminate those and say we're only going to look at 12 to 24 months. That's fine for a specific type of outcome, but it doesn't help you understand the process of timeliness. But eliminating those who shouldn't receive it because they don't actually need it or they're not eligible allows us to examine equity. So always equity, different from equality, is going to be taking a look at this need parameter, like who needs it. And for vaccines, it's pretty easy to figure out what need is because there's generalized recommendations. But for some other outcomes, it may be more difficult. There may be variations in recommendations based upon different types of risk factors for individuals. And so a needs assessment is not a trivial activity. It needs to be done with experts. It needs to be done in concordance with decision makers and policymakers to sort of really understand what the definition of need for a specific outcome is. But luckily for immunization, it's quite easy to define within most contexts. So then we move from talking about inequality to equity, and now we need to talk about equity over what? So a lot of studies use one dimension in order to categorize equity. So we often see socioeconomic status or wealth used because it's easily measured, it's one dimension, it is correlated with a lot of other things. And so in these studies, we see that people are ranked by wealth quintile or household income or something like that, usually wealth quintile from poorest to wealthiest. And that's fine, but there are things that get lost if you're only looking at one dimension. So for instance, gender is often equally distributed across the wealth spectrum. So if there are disadvantages or advantages to accessing services based on gender, you'll never see them if you just look at wealth, because gender's approximately equally distributed across the spectrum, particularly if you measure wealth at the household level and not at the individual level, which most surveys do. And so there are other things too. Education varies, like while it's correlated with wealth, it's not perfectly collinear, so you're going to miss things there. Health insurance coverage could vary in settings based upon wealth. You may actually be more likely to access health insurance in some settings if you're extremely poor than if you're in the middle of the spectrum, because there may be different focuses to public versus private insurance. Like that might not be the case everywhere, but we've seen that in a number of countries. So it's important to take these different things together to create a full picture of what disadvantaged and advantaged look like. And then we can use that measure of disadvantage and advantage as our ranking criteria for equity. So basically, instead of doing wealth quintiles, in our analysis, one of the key features of the VERSE toolkit is that we break people down into quintiles of advantaged and disadvantaged by taking into account these multiple different things, such as where they live, urban, rural, maternal education, socioeconomic status, sex of the child in this case, and health insurance coverage, in addition to wealth and the things that we're most commonly used to seeing. Next slide. And why this is important is because people have a lot of different criteria altogether, and they live in different areas and they have different things. And if we just picked one of them, we might not know how to rank individuals. But if we take all of the different aspects together and how those different aspects relate to our outcome, we can start to build a picture of how multiply advantaged or multiply disadvantaged an individual is with respect to our particular outcome, immunization services, and correctly position them in a ranking. And that ranking allows us to create a line that shows how much of the outcome is obtained by each of these individuals. And so it prevents us from accidentally mixing two people up and straightening out that line so that we can see the real curvature that exists there, and therefore the distribution of inequity that actually persists in our population. And so we can also then take, at the end of the analysis, we'll see this, we could take these different factors and actually see how much each factor contributes to this ranking and the overall inequity. So we can see what matters the most, basically. So in some instances, it might be socioeconomic status that matters the most for determining how individuals rank with respect to an outcome, but for some it might not. For some, you'll see in the study, it might be education that actually matters more than socioeconomic status and is a better predictor of whether or not you'll actually receive an immunization. Next slide. So you can see some examples of comparing across different countries and their demographic and health surveys, different types of measures. So we measure this thing called the concentration index, which is what I said is the difference between perfect equity and what the true distribution of the outcome is. So if you've heard of the Gini coefficient, is really similar to that. The Gini coefficient says how much of total wealth in a population is held by the same percent of the population. So if you had perfect equity, 50% of total wealth of the population would be held by 50% of the population, ranked from poorest to richest. What we're doing is we're ranking people by disadvantage and saying, okay, how much of immunization coverage is obtained by 50% of the population, ranked from most to least advantaged, or least to most advantaged. And so if that's 50%, that's perfectly equitable, right? You want 50% of the population to be getting 50% of the vaccine doses and going to the people who need it. But if that's only 20%, and we see that coverage is 75%, then way more people are receiving the vaccine in the top half of the spectrum than in the bottom half, and we want to change that. And this is different based on whether or not you measure that ranking by wealth or by our sort of composite combined measure that takes all of those criteria and puts them into a single rank. So you can see here for Afghanistan, Bangladesh, India, Uganda, there are differences between what you get measuring through wealth and through composite. And one important thing to point out is that in some countries, you may actually get a negative index. And a negative index means that's pro-poor or pro-advantage. So the poor actually receive immunizations at a higher rate than the rich. But we see that that goes away if you take a look at multiple criteria, because there are other things, again, that matter for equity that contribute to disadvantage beyond just poverty. Next slide. So the VERSE Equity Toolkit generates several different types of metrics. The first is the basic health care service coverage. So we can generate immunization coverage for any of the different immunizations that are included. And this can give just some basic background information on what we're looking at and what we've achieved. Not only can this be done by national level, so for the country, but for each of those sub-regions within the country, really any level that data is available at, coverage estimates could be generated from. And then we have health outcome prevalence. So we can take a look at things like service coverage, zero dose or vaccine coverage individually, DTP, MCV, et cetera, or we could take a look at health outcome prevalence. So we have a couple of key outcomes for vaccines, and you can look at other things too. But for vaccines, we use zero dose. So whether or not you've received any dose of DTP or any vaccine by the age you're supposed to. We have complete coverage where you finish the entire vaccination schedule by the required age to finish the vaccination schedule. And then fully immunized for age, which means you're up to date based on how old you are currently on all the vaccines you should have received. And these are some different outcomes that we can measure sort of prevalence of in a population, in addition to the basic service coverage. So then we have equity metrics. So as I said before, we measure this thing called the concentration index because it's really useful at giving us an understanding of both the level and the distribution of the outcome. So in that sense, it's a really great way to combine coverage with distributional equity. And so that's a basic measure. It comes from the income inequality space. It's used in a lot of other studies. And what's great about that index, which is why we use it, is it's standardized. So you can compare that number across any different type of study that uses a concentration index, and it's comparable. So you could compare this to a study that was done in the HIV space, for example, and you could see whether or not childhood immunizations are more equitably distributed than antiretroviral therapy, for example, among the group who's eligible to receive it. Those numbers are still comparable, sort of 1-to-1, because they're standardized. They range between -1 and 1. And so it's comparable with any study. You could also say whether or not immunization services are more or less equitably distributed than income in a certain setting by comparing this to an income concentration index, such as the Gini coefficient. So you can use this number to compare directly to those other type of metrics and make some generalizations from that comparison. However, that number might not be the most useful thing to generate for policy because it's standardized, it doesn't have an easily interpretable definition. It's more or less equitable than something else. Perfect equity would be 50% of population receiving 50% of the benefit. So you'd get a number that's 0. Perfect inequity would be 1. So you have those numbers in between, but really what those mean on the natural unit scale is hard to say. And so because of that, we generate some other indices such as the absolute equity gap and slope index and relative equity gap and relative index. And what these tell us are either in terms of the gap, the difference between coverage in the top 50 or top 10% of the population ranked by wealth and the bottom 10% of the population ranked by wealth, or the same exact thing ranked by advantage and disadvantage quintiles. So that tells us how different coverage actually is between those groups. So if you got a number like 0.5, it would be that there's a 50 percentage point gap between the highest attaining and the lowest attaining groups. And the relative gaps are just the ratio of those things. You can go to the next slide. And with all of this, you can sort of see on a map, if you're using DHS data with the toolkit, it's great because all of the different geospatial data is included in there. So we can generate maps and heat maps that sort of show by region. for different countries, which areas are sort of the worst off, which are the best off. So for things like PCV1, you can see pneumococcal vaccine, how the variation is in Uganda. You could take a look at an outcome prevalence as well with this map, like zero dose status, and see how the distribution of zero dose status varies differently from an outcome coverage. You could also take a look at equity and see how equity varies differently from both coverage and prevalence of certain things. So this is the distribution of that outcome overall and how equitably it's distributed. So you'll see that not always are low coverage or high coverage associated with high equity, low equity. They may be, they're always going to be partially associated in some way, but there may be, you know, two areas that attain 70% coverage. One of those, the remaining 30% of the population, is basically randomly distributed across unfair factors like wealth and gender and everything. And those remaining 30% are the most vulnerable, and we just haven't been able to get to them. And so there's a lot of inequity. And so that information alone can help us understand how to tailor programs. Are we going to be going after the hardest to reach, or are we missing some low-hanging fruit and we need to design programs to reach them? Next slide. Some of the other things that are generated in the toolkit that you'll see as outcomes in the presentations are the coverage equity plane. And so this can rank different regions or groups on both dimensions of coverage and equity to see where they fall. So in the ideal sense, you'd want to move up and to the right here into that, that quadrant where you're winning and winning. So over time, you're moving towards more coverage and more equity. But we'll see that's not always the case. But this is a good way to visualize these trade-offs and whether or not there is a trade-off, because also often in the literature, there's said to be sort of an equity coverage or an equity increase tension, but that's not always the case. Sometimes these things move really well together, sometimes they don't, and this can help us track areas where the improvement is going in the right direction and areas where they're not. And so here's an example using data from the 2016 DHS for fully immunized for age status. You can see that some areas are doing really well. So Kigezi, in terms of this outcome, is doing quite well in terms of equity and coverage, where you have some areas such as South Uganda that are not doing as well. And then you have some areas that are obtaining really similar levels of coverage, but different levels of equity. And some areas that are obtaining really similar levels of equity, but drastically different levels of coverage. So one could do deeper dive focus groups or understanding with programs, you know, why that might be the case in order to help move everyone up and to the right. And similarly, instead of just looking at regions at a single time point, you can take a look at trajectories over time. And again, we want to always be moving up and to the right, so increasing coverage and increasing equity. But we see over time for specific outcomes. So again, this is fully immunized for age using the 2016 Demographic and Health Survey for Uganda, that sometimes there have been coverage and equity changes in the wrong direction between 2000 and 2006 for this particular outcome, then huge advancements between 2006 and 2011 in the right direction for both coverage and equity. And then gains in coverage or gains in equity and only modest increases in coverage or changes in coverage over the 2011 to 2016 period. So this can help us inform, you know, what's successful, what's not successful, you know, what were associated with the gains we saw in 2006 to 2011, what might have been associated with the things that we saw from 2011 to 2016, and where are these changes sort of most driven by. We can break this down by region and take a look for each region, sort of which ones are gaining and which ones are not during that same time period. So we can see that was the aggregate for the fully immunized for age outcome. We break it down by region here, and we can see that some regions are doing really well. So most northern regions have been pretty successful, central regions pretty successful at increasing both coverage and equity, as well as eastern regions, with the exception of a couple. But we see that some of the western areas have actually gone down in coverage, but have expanded equity during the time period. So there are differences in different areas, and we can sort of use these different pieces of information together to target areas that are, you know, slipping. So as I said at the very beginning, one of the nice things about having all of these composite measures that are standardized with one another and that are similar to other types of measures used elsewhere in the world. So for income inequality is that we have a lot of methods for breaking them back down into their component parts in a standardized way and figuring out how much those component parts matter to the outcome. So what we can do is we can take all of the different factors that we have, so maternal education level, sex of the child, socioeconomic status, urban, rural, the region, health insurance coverage, et cetera, and we can break our number down into the component parts to see how much of the variation in equity is attributed to changes in each of these portions of the indicator. So here's an example for measles first dose coverage from the 2016 DHS in Uganda. And you can see here that if we take a look at all of these different things, actually socioeconomic status doesn't matter that much. Wealth quintile only explains about controlling for everything else about 5.5% of the total variation in measles coverage. It's much more heavily explained by things like maternal education level, which accounts by 45% of the total variation in that outcome, and something like district. So the district you're in matter more. And why this is important is because if you just looked at socioeconomic status, the programs that you might tailor to reach those individuals are different than if you were tailoring programs to reach uneducated versus people in a specific area or a specific district. That may not be the poorest district. So maybe you wouldn't get the most vulnerable first if you only focused on the poorest. So this gives you a better picture about how these different things relate to one another and which of those different factors are actually the best at explaining the differences that we see in the outcome. And we can use this in a number of different ways. So when you control for everything in a model and you have everything kind of together, we can sort of split these different factors into two sides. So one are supply side constraints and one are demand side constraints. And we're able to do this because once you control for education level and socioeconomic status and demographic differences between districts and areas, as well as health service and health insurance coverage, some of the differences that remain attributable to districts are often related to supply constraints, like difficulty of reaching services, difficulty of getting vaccines to those areas, stock out, things of that nature. And then differences between urban and rural areas after controlling for all of these other differences of people who live in urban and rural areas are often due to things like geography, difficulty of reaching and getting services out there. So we can often split these into roughly supply side and roughly demand side constraints based upon what we can interpret from controlling for all of these in one model. So just to sum up about the toolkit and why you might use it. So the VERSE methodology and equity toolkit allow us to do a number of different things. They allow us to hold programs accountable to targets and monitor progress towards reducing inequity nationally and at the subnational level over time. And that's important. A lot of people talk about reducing inequities. It's a buzzword in the field of public health right now. Very few people are measuring it in a standard way, and very few people are tracking it routinely over time. And quite frankly, a lot of them aren't looking at equity, they're looking at disparities, and those disparities may be reflective of inequity, but they also may not, because doing the needs assessment matters. So this allows us to be transparent about what we're doing and what we're measuring, but also be transparent about this is what the data says. If you have equity as a goal, this is one way to measure it. And if you measure it this way, you're either improving it or you're not. And you can use those numbers to hold programs accountable and compare it to progress made in other things as well, to say whether or not this program is improving or not improving at a faster or slower rate than other things that we care about. And that can be used to prioritize funding for equity into different areas, both within and outside the health sector. So we can also use this to identify changes and the contribution to inequity or inequality across vaccines or over time. So we can see differences in coverage, we can see differences in the distribution of that coverage over time in a standardized way, and that's what the standard metrics help us do. It's also good because we can look at all of these things all together rather than every single time doing separate gender ratios and separate ratios for socioeconomic status and separate concentration indices and separate measures of urban rural ratios, and then being like, okay, well, these are all different and they may lead us to different conclusions. overall what happened and what mattered the most. We can see that in this assessment. We can also assess equity coverage trade-offs and determine sort of regions that are lagging on one or both dimensions, areas that are exceeding expectations and what was done right in those areas. We can do deeper studies. So it helps us target areas that are either under or overperforming, and to help us learn from those areas about what may be pitfalls or what might be contributors to success in terms of achieving equitable coverage. And we can also demonstrate empirically the extent to which reductions in one dimension of inequality impact multidimensional composite inequity. So for example, if you saw that socioeconomic status was a key factor, maybe something like a cash transfer or subsidizing transportation costs might be a really good policy to help mitigate the effects of socioeconomic status on outcome. And so you'd enact one of those policies and you do the analysis after. You get data from after that policy is rolled out, and maybe you find that inequity improved, or maybe you found that nothing changed. And that really, socioeconomic status mattered a lot, but maternal education now matters quite a bit, and that was partially correlated with socioeconomic status. So this helps you understand sort of multiple things going on at once to try and get at the picture of inequity that's going on and target your solutions to the biggest determinants. So there are several steps in using the toolkit. If you actually want to use this with your own data outside of the DHS data that I just presented. So the DHS data, we actually have a standardized tool that you can just pull any country, you can link with the DHS. You can see any outcomes that you want for immunizations with all of those countries, and we're working on expanding that to other things besides immunization. But if you're an agency, for example, the Bureau of Statistics or the EPI program or some government agency, and you want to do this, you can format your data and apply the VERSE Equity Toolkit to your own data. So as I said at the very beginning, this requires data. What kind of data? Ideally individual level data or low level data that has information on the different factors that we talked about. So you want an outcome and you want to know who has it and who doesn't have it. And then you also want to know some key features of those individuals. Then you can work with either Makerere or Johns Hopkins, so one partner, in terms of helping customize the toolkit to particular needs. So if you want to do immunization, you're pretty good to go. It's formatted for you. It can look at all of those different things. But if, for example, you want to look at inequalities in HIV services and antiretroviral therapy, or you want to look at inequities in contraception use or uptake of contraception or family planning methods, then you would need some customization of the toolkit, in particular determining that needs variable, right? Like what are the fair and unfair factors and who needs this outcome and who is eligible and ineligible for different types of outcomes. So that process, Makerere or Johns Hopkins can assist you with customizing the toolkit to fit those needs and also conform to the data. And then you can produce and compile and interpret the results on healthcare. And again, the teams can provide support on how to interpret the results and findings that you're getting from the measures, and also, sort of what guidance you could get from that, how those outcomes could be used for different types of conclusions or different types of policy recommendations. And it can generate reports and help you use that evidence to support policymaking and program evaluation within that specific space. So we're really here as sort of a support structure for other people who want to use and adapt this toolkit. And we hope there are other groups that eventually want to uptake this for different things. And with that, I will pass it on to Gatien briefly to discuss some other things that we have in the background on this.
Thank you very much, Bryan. And it's really a pleasure to talk to you all today. I hope that beyond showcasing the work that has been done with the VERSE tool up to now, this may also be an invitation for you to try it yourself. Everything is in open access. Like Bryan said, the program to analyze the DHS data for vaccines is available online. And if you want to learn how to use it and eventually how to customize it so you can apply it to your own data, we prepared a course that is completely fully available online with a certification that's issued if you complete the exams. And so this would allow you to not just download, use the tool, get to know how to interpret the results, which is quite significant to be able to interpret equity metrics and coverage metrics for any health services and make an appropriate judgment for program evaluation or policy guidance from this, but also to learn how to program it. It's based in R Studio. It works really well. It does require a few programming skills, but things that you can really learn quite easily for free online. And the program is well documented to show you here, these are the different aspects you can customize to keep the overall structure of the generating the composite ranking, etc., but with customized inputs. It's not going to always be the ones that were listed here, health insurance, maternal education, etc. It depends on what you collected with your data. And so customizing those, but also customizing the outcome that you're interested in. And so to give you full access to this, there is also a post-webinar folio, which I will post the link in the chat right after I am done speaking, that you can access. It has links. It's on Google Drive. There's no paywall, anything to it. So you just access it. And there's a list of links that you can access to download the tool, download documentation, look at the demonstration video that shows you how to use it, or access the free course that is online. So simply click on this document that you'll see post webinar folio, and you'll have a list of links that you can access like this. We want to acknowledge, of course, that this was generously funded by the Bill and Melinda Gates Foundation, and we're very grateful for all the dedicated collaborators and partners without whom this project is absolutely not possible. So I wanted to put this here. And as we transfer to the next speaker, I will put here QR codes that you can scan with your phone that will give you access to either connect with us over email or access the post-webinar online folio, which I recommend all of you to do. Thank you, and I will pass back to Anthony.
Great. So thank you so very much, Gatien, for so for that brief overview of the course, but also thank you to Bryan for giving us a very succinct overview about the VERSE toolkit, what it can do, what it can be used and for, and possibly opportunities for adaptation to other contexts. So thank you, and I would request the participants to hold on to your questions in case you want to voice them over. We shall have an opportunity hopefully at the end of the presentations, but in case you have some burning questions, please feel free. I invite you to feel free to write them over in the chat so that we are able to either answer them in real time or even plan to answer them at the end of the presentation. So we have two more presenters for this afternoon. So our next presenter will be Dr. Ronald Kananura, who is coming to tell us about the distributional benefit cost analysis methodology. So this is work that we did under the VERSE project here in Uganda, and it focused mainly on how the methodology can be used to predict return on investment and use of the route vaccination. So welcome, and over to you, Dr. Ronald.
Yeah, thanks very much, Anthony, for that debut. Just a mic check. I want to know if you can hear me.
Very well. Please go ahead.
Thank you very much. Yeah. So in this presentation, definitely, like Anthony has said, we shall be talking about coverage and distribution benefit cost analysis of rotavirus vaccine from the time, of course, it was introduced. And the key message here is actually how we can use routine health data to do this, but also trying to understand the cost, the benefits cost, how it distributes across different socio-economic groups, but also the return on investment. This is part of the paper that we've actually submitted for publication. It is still under review, and we hope by the early next year we should be able to have it published. Just a bit of introduction. Definitely, we know the global commitment that is about ending preventable diseases, including diarrhea. And of course, we've observed how morbidity and mortality due to diarrhea has changed. But definitely, diarrhea remaining the leading cause of mortality, particularly among under 5 years aged. And we are also aware of how diarrhea is actually among the top most diseases that contribute to the burden in terms of hospitalization, and of course in terms of household costs. And from the studies that we've done, on average, $79 is spent on each case of diarrhea episode. And of course, we also know that various pathogens, and one of them is rotavirus, which accounts for between 36 to 46% of all diarrhea cases in Sub-Saharan Africa. And the 20 per 100,000 under 5 mortality rates, of course, are due to rotavirus, with, of course, Sub-Saharan Africa contributing the largest share. And so we know there has been the integration of rotavirus vaccine within the routine immunizations, including in Uganda, where it started in April 2018. And so in this study, we are trying to examine the net benefit of the rotavirus vaccine in Uganda based on different data sources. And the data sources we have, we used routine health facility data from 2014 to 2021, and of course also some other empirical studies, including some of the data that actually we collected in Uganda and some other countries. And in the analysis, we consider the direct costs, indirect costs, but also in terms of modeling, we apply interrupted time series analysis to understand the effect of rotavirus vaccine, but also trying to come up with predicted estimates. And we, of course, we know there are usually challenges of getting the denominator in terms of, when we are using the facility data, but also in terms of when you are linking this, of course, to available other data sets. So our estimates of the denominator, we use an indicator that we know that is closer to universal, and one of them is actually DPT1 that is estimated to 95% in Uganda. And so we use this to get the denominator that we can use to estimate the coverage of Rota vaccine, but also trying to understand the incidence of acute and persistent diarrhea. And in terms of modeling, we use a negative binomial regression model with the aim of understanding how rotavirus vaccine could be associated with the reduction in hospitalization. And of course, using this, of course, to do predictions. And in the model, we controlled for other confounding factors like the number of health facilities in the district, the population of under 5 children, and of course, when the vaccine started, the vaccination period, and other stuff. So we know usually in the aggregated data, there are usually issues of outliers that arise, particularly when, of course, we are recording, these data from the registers, but also entering this in the HIMS, the HIS2. And so to do this, we have to actually check for the outliers and then try to see how this could be adjusted. So in this analysis, we assessed for that and then adjusted based on the mean absolute deviation. And we also know there are issues of non-reporting. For instance, we know usually the private facilities usually actually don't, a few of them report. And so the adjustment was based on that formula, but also based on what we know in terms of where where the population always access services from. And so we used an adjusted proportion of 0.25 of 25% as the number of facilities that private facilities that don't always report in the DHIS2. In terms of cost benefit analysis, this is really just the simple mathematics, where the cost benefit really getting the cost you incurred and then the cost you expected, that difference. And of course, we considered the direct costs for vaccination, but also the indirect costs. And then later also did the distribution benefit analysis, based on that. Yeah. In terms of the indirect costs associated with mortality, so we also calculated this, trying to actually know how much one is, of course, the return on investment. The second one is the contribution of rotavirus to the national GDP in terms of, in economic terms. And we use, of course, different methods. One, of course, was based on the primary data that we collected, and then also using the GDP per capita, which in some sense is actually used to validate our methods. And later, as you see, you will see how the two are aligned. And to do this, of course, we consider the average income per year for the household, but of course for the GDP method, we use GDP per capita, and then also consider the labor force participation rate, which is estimated at 75% in Uganda, and then also the number of activity years, which is estimated through life expectancy less the initial age of employment, which I think in Uganda, it is at 15 years. And then return on investment, where of course we get the net benefit divided by the total costs towards vaccine. And we did this, of course, considering two scenarios. So the first scenario is if there is a full protection, assuming no death. And then also the second scenario is accounting for the deaths due to rotavirus. And we considered a 2.5% case fatality rate. So in the results, so in terms of the quality of data, I think in terms of the quality of data, the quality of data in the DHS is actually improving. We see in terms of reporting, at least as of 2021, at least 80% of the facilities were reporting. And also, so to do this, of course, if we have a tolerance of 10%, so we see at least, all facilities now actually, most of the facilities are actually their reports. And so in terms of coverage, and this is where, of course, we want to showcase how this could be used also to measure coverage. So we see as of 2021, Rota1 dose 1 vaccine is estimated at 90%, and then dose 2 at 65%. And in terms of the variations across the districts, we can also, of course, see some differences with Busoga, Bugisu, Busoga, Bukedi, and Lango having, lower estimation compared to others. And of course, we also tried, of course, looking at the trend, we try to compare our estimates with the external estimates, particularly the WHO and the UNICEF estimates, to just show actually how consistent they are. And we see, of course, there is no gold standard, but we see to some extent rotavirus vaccine dose 1 is to some extent matching the UN estimates. If we consider actually the confidence intervals, we would find that actually all within the same confidence range. But in terms of those two, we see there some variations, and the UN seem to actually give us over higher estimates compared to ours, which we think perhaps the UN actually these are over estimates. And then in terms of TPT3, our estimates are really close to the UN, some external consistency. So meaning that really we can actually facilitate data to measure the coverage, the immunization coverage. So in terms of distribution of diarrhea, so, and this is of course based on the VERSE approach, and doing this, of course, we also try to consider some other doses that are usually provided with Rota vaccine. For instance, we know DPT2 or DPT1 goes with dose 1 of rotavirus, and then DPT3 should be aligned to dose 2 of Rota vaccine. And so here we see in terms of the distribution of diarrhea in Uganda, we see 63% of children with diarrhea actually I mean, 60% of children in Uganda belong to a lower 60% of social economic class. And in terms of the diarrhea, 67% of diarrhea prevalence cases is a share of the lowest 60% of the social economic class. And the same applies to 64% of those who access treatment belong to the lowest 60% of the social economic class. So in terms of access, distribution of access to rotavirus, those we see definitely we see some gaps with the lowest class, of course, left behind, okay? And we also see actually between 2019 to 2021, we see some drops in terms in the immunization utilization. We don't know, of course, maybe we need to check this if that could be due to COVID and other shocks. So in terms of how these affect the hospitalization, we see here, and this is the model that is based on the negative binomial, which is to some extent, of course, the same as a Poisson model. So we see a 1% increase in rotavirus vaccine leads to a 1% reduction in diarrhea hospitalization. And here we would actually considered rotavirus vaccine 1. And we also see diarrhea hospitalization reduced by 10% after the introduction of rota vaccine. And each day, each additional month, it shouldn't be a year, sorry, each additional month following the rollout was associated with a 10% increase in the reduction of diarrhea hospitalization. So, so of course we use that modeling, of course, accounting for other factors to do the predictions and versus what we are observing. And we see an increasing trend in terms of hospitalization reduction with close to 60% reduction in 2021. So in terms of costs, we see the productivity loss due to mortality is between 92% and 82% of the total costs. And this is, of course, due to the significant variation associated with an average of 40 years of life lost with each death. So here we look at the costs where we have, of course, like I said, we have two scenarios, okay? And the first scenario is full protection. So where we are using, of course, the primary data that we collected here, and also the GDP. And as you can see, you see actually the two graphs almost behave the same. So somewhat actually the GDP approach is validating what we are doing. What we are doing, of course, using the primary data, and we see in terms of costs in 2010, so there was $186 million spent on diarrhea treatment, and then also into and then in terms of what we actually spent is 2,129. So this the blue shows what we expected, and then the other color shows what we actually spent. And so if you get a difference, definitely it gives you the net benefit. And so in terms of scenario 2, sorry, it's this bar here. So in terms of scenario 2, where we are including death, so we see we expected to spend 3,136 $1 million, but what we observe, we actually spent $1,926. So which in terms of net benefit, if we get expected minus observed, then that means actually it gives us a saving, a positive value, which means actually there was a saving. And when you compare the primary data and of course the GDP method, we see actually they are almost the same, meaning that actually our method and of course the data that we collected from the household depicts what should be. So in terms of the overall direct costs, so the government was expected to spend 42, but of course we observe that actually we 62 as a total was spent. Of course, this is expected because of course we have not actually spent many years after the introduction. But if you look at the years from 2018 2021, we see really a reduction, so sort of in terms of the costs. And the same applies to the household. So what we observe is actually less than what we should be expecting. So meaning that on the side of the household, in terms of out of pocket expenditure, there is some saving. So I think I've tried to explain this initially in terms of the net benefits, really the difference between the observed and the expected. And we see if we use the GDP and also the primary data, we see the graphs actually behave almost the same. In terms of return on investment, from the primary data, we see one unit cost on rota vaccine when we consider the scenario of having some deaths. In the overall, the one unit cost actually leads to $21 million. And then if there is a full protection in terms of GDP or primary data, in terms of GDP, a one unit cost on vaccination leads to a saving of $53 million. And so in terms of distribution cost analysis and net benefit, so we see in terms of out of pocket, we see really the net benefit is actually higher among the lower socio-economic class, and this is almost consistent across the 4 years. The same applies to the return on investment. So, which means actually that the Delta vaccine was actually is benefiting the poor. So, meaning that's actually innovation. So in conclusion, so we've seen that definitely, although there are disparities, across the regions, we see the vaccine really has a contribution to the economic development, considering the partial protection, considering the full protection. And we've seen, of course, the return on investment when we exclude indirect and indirect benefits, and also the mortality impact, which really underscores the importance of prioritizing and strengthening the vaccination efforts. And most importantly is really how we can actually leverage the routine health facility data to be able to monitor such kind of interventions. So as also we know that definitely as the government or transit from reliance on donor support to self-financing, of course we should not overlook the high costs at the initial stage, which in most cases sometimes, of course, scares the policymakers. But in the long run, we see really investing in vaccination really gives us promising returns on investments. So as I conclude, I think we need to, of course, acknowledge the Minister of Health for having or giving us the data, and of course the Bill Gates and Melinda Foundation. That is it for me, and thank you very much for listening. Yeah.
Yes, fantastic. So thank you so very much, Dr. Ronald, for the very interesting and insightful presentation. I believe that each of you, wherever you are quite not only intrigued, but by how much actually we can do with what we have, but also, I mean, looking within what different areas of specialty and work and expertise we can actually be able to how this would literally fit within what we are currently doing. So, and I would request that if you have any questions, a kind reminder, please put them in the chat, and we'll be able to answer them in real time. But if you want to voice over, maybe we shall do that after our last presentation. So which is related also to the VERSE work. So that we've also been doing. So just as a background, we have Uganda has been we call it the flagship country that has championed the adaptation of the VERSE toolkit, not only to local context but also deploying it even in other areas. So the primary focus initially was for the immunization program, but later, having engaged different stakeholders and policymakers, they had actual additional interest, and some of those we've since prioritized to other areas, so including maternal and child health, HIV/AIDS, certainly family planning, and others. So within that regard, we've also been able to speak with several institutions who have not only expressed the interest in adapting the VERSE toolkit to fit their data sets, because the toolkit uses already existing data, but only also to institutionalize it to help generate evidence to inform their programming. So some of those include the Uganda Bureau of Statistics, which actually is planning even on incorporating these within their routine reports, but also UNEP, the Ministry of Health. So we've also spoken to IDRC, that is the Infectious Disease Research Collaboration, and then PMA. I think colleagues at the School of Public Health know the PMA project, championed by Professor Makumbi. Then we've also spoken and onboarded colleagues from HEPS Uganda, which is the local CSO, to model this data on HIV data that they routinely collect, and then also UVRI to see how they can adapt this toolkit to inform disease modeling and also HIV research, certainly, which they have been doing for over 25 years in Uganda. So thought that would give you this background, and also finally introduce our last speaker, but certainly not least, that is Dr. Jaffa Okling, who is a seasoned statistician with over 15 years of experience in conducting statistical analysis and modeling of infectious diseases. So Jaffa led adaptation work for the VERSE toolkit at IDRC, and he will be speaking more about his experience. And for those folks who are interested in learning what does it take, what does it mean, I think Jaffa is going to speak just directly to that. So Jaffa, most welcome. The floor is yours.
Thank you, Anthony. Once again, I'm Jaffa Okling. I'm happy to give this talk on experiences in adaptation and use of the VERSE toolkit in the context of equity in long-lasting insecticide net use. I'm presenting it on the behalf of the whole team, the VERSE team. So as a way of introduction, this has already been introduced, but we know that the VERSE methodology has originally been used for composite vaccination equity assessment metrics, which was heavily dependent on these two indices, which were on socio-economic equity combined with measures of direct unfairness in healthcare access. In the context of the work we did, the VERSE toolkit was customized to assess inequities in the early line use. So as a way of giving an overview of the data set we used and sharing our findings briefly, we used secondary data, which was from a cluster randomized trial, which was conducted in the eastern and the western part of Uganda. This trial was embedded into a national early line mass distribution campaign with a main objective of comparing two major types of nets, which were the conventional early lines and the PBO nets. Here in this trial, the health subdistricts without any indoor residual spraying were generally eligible for inclusion in the trial. And more importantly, each health sub-district was considered as a cluster. And over 104 of the health sub-districts were included in this study, and these were located in 48 districts. The health sub-districts were selected purposefully into the study, and a series of cross-sectional surveys were conducted at a time before the national early line distribution campaign, then 6, 12, 18, and 24 months. So we use this data and we apply the VERSE toolkit to analyze the early line usage and the equity among the household members before and after a national mass campaign in these 48 districts of Uganda. So as a way of just understanding briefly of the study population, in each of the time point, overall, over 200 household members were surveyed in each of the time period. And in relation to gender, mostly, or about 50% within the range of 50 were female in each of the time points surveyed. And still slightly above 50 of the household members were above 12 years of age, and most of the household members were first-degree relatives in each of the house in each of the time point. And of course, as our inclusion criteria was that the inclusion criteria was there shouldn't be any history of IRS, which is implying that almost all the participants reported not to have received indoor residual spraying. So what did we see? In relation to the concentration indices, we see that all these indices were positive. And for instance, when you look at the Wagstaff concentration index, it was around 0.131 at baseline, and then it ranged between 0.023 to 0.051 in the subsequent time points following the national distribution campaign. These indices were all, as I said, they were all positive, and clearly they indicate that the inequity in early line use was more prevalent amongst the more privileged people. So when we went ahead to try to look at the early line use at the different time point using the absolute equity gap values at these different points, we say that at the baseline, we had around 26, the value of 26, while at 6 months, it was around 10%. And then we have 14% in the subsequent. Given that our red line, vertical line here indicates the time when it was masked, we see that after a mass distribution campaign, we see the AEAG values dropping to this. But we clearly see that at baseline alone, that at a 20% most disadvantaged household would need to increase early line use by 26 percentage points in order to have a similar level to the top 20 most privileged households. As we see, after LA line use, we see this value dropping, indicating that the LA line distribution improves, that reduces the gap of LA line usage. But however, after 6 months, we see it again moving up. Potentially, there are potential explanations. Maybe it could be the wear and tear, possibly could explain that. But this is what we are saying. And then when we try to decompose inequity in bed use, looking at the baseline, looking at each time points, what did we see at baseline? We see that the most contributing factor at baseline was actually socioeconomic status, as we see, although some other factors were also contributing, like gender, being a female, mostly contributing to 5.3, and then consenting age, contributing to 3.2 variation in the LA line use, while relationship to the household head contributing to 39.9%. Okay, this is also possible because we know that there are potentially several sources of LA lines, and most likely maybe the effect of the wealth status. Some people being in position to afford could maybe explain why we have the socioeconomic status popping up higher. But when we move to the 6-month period, see the pattern slightly changing. And here we see that at 6 months, the most contributing factor is relationship to the household head. And this pattern consistently remained at 18 months, at 12 months, as we can see, although it even improved slightly, but of course the difference is not so, but still what we're seeing that the relation to the household head was a big contributing factor to the variation in LA line use or bednet use. And as I said, this pattern remains consistently the same, even at 12 months. And likewise, also in 18 months, still the relationship to the household head, which was around 66.6%, was the biggest contributor in LA line use. When we combined all the study periods together, still the pattern did not change. It's still the relationship to the household head, which was contributing to 53.8%, was the major contributor to LA line usage from what we said. This work is work which we are putting together to submit. Hopefully before the year ends, we should have submitted this for publication. So what did we experience in using the VERSE tool? One, we note that the VERSE tool, from our experience, is more palatable when you are using categorical covariates. So implying that possibly if you have to reorganize your data, if you used categorical variables, it would be so easy for you to use the VERSE toolkit. Also, secondly, we note that the VERSE tool has unlimited usability. For instance, we have used it here to look at the observable patterns of LA line usage over time. We also used using a different data of around the Kampala, immunization around the Kampala, and it was working perfectly well. So we generally noted that the VERSE tool has unlimited usage as long as you can customize it to do what you want. So if anybody is interested, please, you're welcome. It is a very interesting tool. Then we also noted that in order to use the VERSE toolkit, you need to try as much as possible to collect all the relevant data. Because in our case, we're seeing some bit of unexplained variation, which was suggestive that there are other factors which we did include, which could potentially be useful. But of course, the results were so appealing. And also, we noted that the use of the toolkit itself only needs basic R skills. If you have those basic R skills, you can use. You don't use to be an expert exhaustively in order to use the toolkit, which is an advantage since some of us may not be having thorough knowledge in R. Just need to get a team, as we're told, could approach School of Public Health and Joe in order to customize for you. And then on the other side, we also experienced that the tool uses extra libraries, which to some extent adds the complexity between interoperability between library versions. That's what we observed. In overall, in our conclusion, in our experience, we highly recommend the VERSE tool, and we say it is relevant and only requires basic R skills, which anybody can easily learn. As I said earlier, that this work, we're trying to put them together, and we're writing a manuscript. So thank you for listening. Back to you, Anthony.
Great. So thank you so very much, Jaffa, for that very insightful and interesting presentation. I believe there's also been a lot to learn, not only on what actually we can pick from not only his presentation, but also from the other earlier presentations or speakers. So it's my honor now I don't see in the chat, I haven't yet seen any questions come through. So probably I would invite any participant from the audience to maybe possibly raise their hand, and then can, yes, be given opportunity to speak. Gatien, I think you should be able to handle this on your side. Some people have hands up.
Can anyone hear? I can't hear anything.
I think Gatien's muted.
Apologies.
Yes, we can.
I made the basic mistake. Please go ahead with your raised hand. You have the floor. I think it's Dr. Suzanne, if I'm not mistaken. Yes.
Thank you very much, Gatien. My question goes to Dr. Jaffa. I'm curious about relationship to household head on the use of LLMs. Does that mean husband, child? Who is more likely to use this? And what variables did you include in relationship to household head? Thank you.
Right, thank you, Dr. Suzanne. Jaffa, you want to respond to that as other colleagues?
For sure. Thank you, Dr. Suzanne. The relationship to the household head was a categorical variable, where the reference category was the household head, and then the second category, which was the close relatives, which included the children and the wife. And then the third category was the distant relation. Maybe we're taking relatives, the distant relatives, beginning from the level of grandees, extended families. Then we had also the fourth one, which was the unrelated.
Okay, Jeff, I think we can't hear you anymore, so I guess you're still speaking.
Okay. You lost me?
Yes.
Okay. I was saying that the last category was those ones who are unrelated to that. So implying that if the reference category was those ones, it was suggestive that being close to the household partner was more likely to use the net, implying that the close relatives, the spawns and the children, were more likely to use the nets. I don't know whether that makes sense.
It does. Thank you very much.
Great. Fantastic. Thank you so much for your response. Yeah, I see Dr. Ronald has also written something in the chat saying that use increases with the relationship of the close. I think how close the member is or individual to the household head. So using the social network theory. Yes, that's also very true. I don't know if I don't see any other hand from the audience. I want to think that there are no more questions. But in case there is any that comes up along the way, we would interest you to reach out to us, and we are happy to discuss further, especially if you're either planning on a large project. Especially these things are very important to plan ahead, to incorporate it from the start in terms of being intentional, how you measure equity, what tools you use, and also the approach, so that you also include also those questions, relevant questions within what you're tracking or indicators. So we also encourage you to reach out to us for not only guidance, but also respond to any questions or even potential collaboration if any. I'm interested in this area. Thank you. Another great thanks to all our speakers today for the very insightful presentations and sharing your experience on using VERSE. And we look forward to even sharing, having a lot more opportunities in the future to share with the wider audience and public, and also the academia on what much more actually we can use using this methodology. So maybe I will hand over to Gatien as we conclude, and for final remarks and parting remarks.
Sure, thank you very much, Anthony. Well, it was really a pleasure to have you all today. and to be invited to this fantastic webinar. Thank you very much, Dr. Suzanne, as well, for inviting us to join here. Again, everything is made to be easily accessible online through open access, through courses, through the different resources we put forward. So here on your screen, you still see the post-webinar online folio that you can download and use to link you up with different resources. I believe in the different panelists encourage you, if you're a student looking for a dissertation project, if you want to consider adding an equity assessment to it, please go ahead. The way I would go about this is you can get an introduction to the project, of course, get to know this point of view, or there will be a recording of this session that we will make available to you. So watch the different presentations, applications of the tool, the different considerations for interpreting the equity metrics, which is a big discussion in the field of health economics. After you get a bit familiar with this, the course is really your best resource. It's going to show you how to analyze DHS data for vaccine outputs, which is a program that can allow you to generate maps, generate equity coverage trade-off planes, all the equity metrics we've seen today. And if you want to have a more advanced use of the tool and program it for your own data set, which is what most people are interested in doing, the course is teaching you how to generate those equity metrics, how to tailor the program to do this. And so how it does this is you precise what data set you work on, what outcomes you want to look at. And when you look at outcomes, the best type of outcomes you should use is a binary outcome, 1 or 0, because it's easy then to determine whether the person not just received or not the service, but also eventually what's eligible or not for it. And that's the next step, is customizing the different inputs, the different parameters, the FAIR parameters, which are the eligibility criteria, like age for a vaccine, or whether someone should receive a specific service in healthcare. And then unfair variable, which is everything else, like socioeconomic status, region where the person lives, etc. All of these parameters that should not contribute to accessing the healthcare service. So I had a quick question from Nuradin about how to scan the code here. The best way is through your phone. If you have a smartphone, you can basically, with your camera on your smartphone, you can try to take, if you are about to take a picture of this QR code, you're going to see a link that is going to appear right below this QR code. If you press on that link with your finger, you're able to connect immediately on your phone with the Google Drive document. Otherwise, there is also in the chat the link for this, the post-webinar portfolio, and as well how to contact the different speakers, panelists for today. So for Dr. Patenaude, Dr. Kananura, and Dr. Okiring, you have either an email or the Twitter X handle as their preferred contact method. On this, I'm making sure we answered all the questions. The floor is still open if anyone would like to raise their hands. Otherwise, we can end the webinar here and we can follow up as you need. Anthony?
Yeah, thank you so much, Gatien. And possibly I also don't see any other hand. So maybe we'll invite the chair to conclude, give us final remarks, then we can conclude the webinar for today. And special thanks again to our partners, long-standing partners, Johns Hopkins IVAC Center, certainly by a team led by Dr. Bryan Patenaude. Thank you so very much. And certainly Gatien, Josh, and everyone who really appreciate not only the collaboration, but also all the support and partnership that we've held for many years since then. So much appreciated, and we hope to keep this going as we've discussed in the past. So we'll welcome Dr. Suzanne to give final remarks and conclude the webinar.
Yeah, thank you very much, Anthony, for a very enlightening lesson on equity and how we can use the tool and how we can explore the multifaceted nature of equity. I have personally learned a lot, and I'm sure even the people in attendance have learned a lot. I have noticed there are some students online, and these could be interested in taking this further. So thank you very much, our partners, and thank you for making this available to be adapted and used for different conditions. Hopefully the students can get access to the data they need to do this. And we look forward to working closer with you and perhaps even have you share on any other pieces of work you could be doing. Thank you very much. Thank you, Anthony. Thank you for bringing everyone together. Have a nice evening and a nice day, depending on your time zones. Goodbye.
All right, thank you. Bye-bye.
Thank you very much, everyone.
Yeah, thank you so much, everyone.